I believe we can get started, and I'm very happy, honored today to present Professor Michael Häfner from the Strasbourg University Hospital that will be speaking about diagnosis, indication, and decision-making for ESD in the esophagus.
Well, thank you, Gloria. Thank you for all your organizational work and keeping us busy and making this possible. And thanks everybody for joining in. Regarding the chat function, I'm sharing my presentation now, but unfortunately in this mode, I can't see the chat window. So maybe I'll answer the question. If there are any questions for me, someone give me a hand and telling me the question, or I'll answer them at the end of my presentation. Okay, so let's start with ESD in the esophagus. The topic today will be the diagnosis, the indications, and the decision-making for treatment. And I'm actually quite happy that I'm allowed to talk about the esophagus because I think it's one of the most exciting locations to perform ESD. Well, a little bit of background. As we all know, ESD was developed to overcome the limitations of endoscopic mucosal resection, which is mainly the limited size of en bloc resections, and therefore the difficulties the pathologists got with assessing the complete resection. So if a pathologist gets, let's say, this tumor you can see on the right-hand side of the screen in several pieces, it's very hard for him to judge whether this has been a complete resection, and that's why we need ESD in order to completely resect the lesion in one piece. When it comes to the esophagus, the main indications are clearly the squamous cell cancer mostly, also a little bit of the Barrett's cancer, the adenocarcinoma of the esophagus, and rarely submucosal tumors. Let's start with squamous cell cancer. Nowadays, endoscopic resection is considered to be the preferred method of curing early esophageal cancer because surgery is associated with a lot of complication. It's maximally invasive compared to endoscopy. And on the other hand, early squamous cell cancer has a low risk of lymph node metastasis. In order to assess the risk for lymph node invasion, we have to look at tumor histology. We're dealing mostly with a highly differentiated cancer. Depth of invasion is crucial. Tumor differentiation and lymphovascular invasion. As for all the other organs, we're doing ESD. So mostly our data comes from surgical studies where early cancers have been resected and the number of lymph node involvement has been assessed. This is a fairly large study. Although very old, it has been published in the surgical paper and it's based on surgical data, 2,400 patients. And as you can see, in case of M1 or M2 disease, the risk for lymph node metastasis is definitely low and lower than the risk of surgery. That changes when we have infiltration into the M3 layer and especially into the SM1 layer, so the upper third of the submucosal layer. Then we can expect 10% and 26% lymph node metastases respectively. So, which makes it clear that our play field for ESD is mostly M1 and M2 situations. Also, ESGE in their recent guidelines recommends ESD as the first option for early squamous cell cancer in the esophagus. This is based on 15 publications. You can find them in the guidelines published in endoscopy. And here we have en bloc resection rates for ESD between 80 and 100%, complete R0 resections in, again, 80 to 100%, and very low rates of local recurrence in the worst study that was about 2.5 or 2.6%. So for the good results, the relatively low risk of the procedure, ESD is the preferred treatment modality for M1 and M2 squamous cell cancer of the esophagus. As for the diagnosis, in Japan and China, Zoom endoscopy is routinely used. Here in Europe, few centers are equipped with those kinds of equipment, So we mostly base our decision whether a lesion is suitable for endoscopic resection on the macroscopic appearance, whether it's a flat or a sessile, or a flat and elevated or an ulcerated lesions. And you all know the Paris classifications. O1 is the elevated lesions and O3 is the ulcerated lesions. Those usually have submucosal involvement and therefore are no candidates for endoscopic therapy, while Paris classification 2, the flat lesions, are usually eligible for endoscopic resections. I don't know if you see my cursor. The problem we're having with early squamous cell cancer that it's usually flat and hard to spot. You can see a slightly depressed, slightly more reddish area in the 1 o'clock position. This is a cancer. So one of the major issues we're facing is actually finding the lesions. Again, some words about correlation between the Paris classification and infiltration death. As you can see, flat lesions usually have a very shallow infiltration of the mucosal layer M1 to M2. And if they are smaller than 2/3 of the circumferential extent, those are the lesions we're looking for. Those are the indications for ESD. The background is that here we have a very low risk situation regarding lymph node metastases, as I've shown you before from the surgical paper. And as I've already told you, the morbidity and mortality of esophagectomy outweighs the risk of lymph node metastases in these patients. In infiltrations up starting M3 or deeper, then the risk of lymph node metastases increases drastically. So those are patients which are candidates for surgery. There are relative indications for ESD in those patients, especially if patients are not fit for surgery. Also, if lesions are very shallow when it comes to the infiltration of the submucosal layer, and if the lesion is not too big. So those are borderline lesions, and often we only know once we get the histopathology results back if we dealt with a M2 or an M3 or SM1 lesion. So this is an example. This is just, I tried to not to show you videos today because of the character of the webinar. So I focus on still pictures. You can see a flat elevated lesion, a 2A lesion in the 5 o'clock position. This was an SM1 situation, but without any risk factors. So there was no infiltration of lymph vessels or small vessels, and it was completely resected en bloc with ESD. So this was a borderline situation, but the patient was cured with ESD. As far as adenocarcinoma is concerned, the role of ESD is very limited. There are several reasons for that. First, EMR in the large majority of cases is more than efficient for resection of Barrett's cancers. They're usually small, and even if we perform piecemeal resections, due to the low rate of lymph node metastases in high-grade dysplasia or TA1 carcinoma, usually the EMR is enough. Of course, we follow those patients with ablation therapy, be it either with cryo or with radiofrequency. So those patients receive a combined treatment of resection and ablation. Again, some data in a meta-analysis, we found that those early cancers have a very low risk for lymph node metastases, and only in patients with early cancer that goes up to still below 2% in case of intramucosal cancer. As I've already told you, ablation is the standard for non-visible lesions, although in my experience, there is no invisible cancer. And we know this from the Dutch papers, that if you're an expert, if you know what you're looking for, you always find the dysplasia or the cancer. So Barrett's ablation is usually performed after endoscopic resections. In any visible or flat neoplasia, we perform usually EMR. here you can see such an example again in the 1 o'clock position, a slightly elevated lesion with a different pattern. You can see this is using iScan, and this can be usually resected quite easily with EMR. There are some comparison studies between ESD and EMR, and interestingly, there is no significant differences in local recurrence rate, positive margins or lymph node positivity, complications, or patients requiring surgery. And I want to go a little bit more into detail. This is a study from Germany. It's a randomized controlled trial comparing EMR and ESD for the treatment of Barrett's cancer. Although I think the approach is not the right one, as you will see, because usually we really have to carefully select patients which are eligible for ESD with Barrett's cancer. So probably randomization was to be expected, not to yield perfect results. However, 40 patients were randomized. They either had high-grade dysplasia or early cancer, and they were randomized between ESD or EMR, followed by radiofrequency ablations. As was expected, the rate of R0 resection was much higher in the ESD group compared to the EMR group, and that was significant. However, at the end of the day, there was no significant difference in complete remission from neoplasia after 3. It was 15 out of 16 patients were in remission for ESD and 16 out of 17 for EMR. However, there were some severe complications in this study. 2 perforations occurred in the ESD group, and you all know that severe complications are very, very rare in EMR. Here in this study, 1 patient even developed a mediastinitis, and that's a life-threatening complication. So ESD is therefore reserved for special situations. Usually it's very large lesions, or in my experience, lesions we're not sure whether it's an proximal gastric cancer or a Barrett's cancer. And of course, you should only do that if you have considerable experience with ESD in the esophagus. Here are some of our cases. This was a polypoid Barrett's cancer. You can see it on the left-hand side of the screen. It's a polypoid lesion. It's a 1S lesion. And from the biopsies, it was clear it was cancer, but the pathologist couldn't tell us whether it was gastric cancer or Barrett's cancer. So we decided to perform an ESD. And you can see the results at the right-hand side. We had to do the whole procedure in retroflexion. It was quite complicated. The wall is very thin in the proximal part of the stomach, but at the end, we managed to completely resect the lesion. It was an M2, L0, V0, and R0 lesion, and it was Barrett's cancer. Another example, on the left-hand side, you see the lesion in retroflexion, the patient had a hernia. And here, again, you see a more polypoid protruding lesion. This was an SM2 infiltration. Although we managed to resect the lesion en bloc, there was infiltration into the depth, so we have to send the patient for surgery because of R1 resection. In my opinion, or in my experience, we don't see really those terrible complications like perforations, but those are lesions which are extremely demanding and time-consuming and challenging to resect. So this is definitely a small niche and is rarely performed in our units. Another niche, which however I find interesting, is submucosal tumors. We must not forget that there are quite a number of different submucosal tumors in the esophagus, mostly leiomyomas, but also GIST, schwannomas, and granular cell tumors. And most of them are benign and have a very low risk of becoming cancer, but some of them might be big and even cause symptoms in those patients. And of course, in most patients, we have to deal with their concerns regarding malignancy and their wish to have the tumor resected. The 2 techniques we have available are the standard ESD technique or the tunneling technique, like for POEM or GPOEM. And regarding the tunneling technique, there is recent large study from China, 286 submucosal tumors in the esophagus. We'll never see that in Europe, and we'll never be able to do that in Europe. And in this study, en bloc resection was possible in 85%. So you can see even for inexperienced hands, this is a challenging procedure. And on the other hand, the complete resection was 100%. Perforation occurred in 2 patients, which mostly reflects the experience the Chinese doctors have, and delayed perforation in additional 2 patients. No other complications like severe bleedings were observed. We also treated some patients with submucosal tumor. Here you can see a case of a myoma in the esophagus, which wasn't so small. That's why the patient was concerned. We did the US and then decided that we could try to resect it safely. So we didn't use a tunnel technique. We used a standard ESD technique. And as you can see, we managed to get the lesion out in 1 piece and without any complications. Another case, this is actually the most common case we find in the esophagus, and usually those are small, are granular cell tumors. Most of them can be resected with mucosal resection if the patient really wants to get rid of them. This one was a little bit larger, so we decided to perform an ESD. On the right-hand side, you can see some hemostasis performed with the APC probe. But again, usually those are small and can be treated easily with EMR if needed and if wanted by the patient. So those were the indications. So mostly squamous cell cancer, certain cases of adenocarcinoma, and a few and rare submucosal tumors in the esophagus are our main indications for ESD. More important even than doing the actual procedure is to choose the right patient. So what we have to do is carefully assess the lesion and make sure we choose the right patients for either surgery or endoscopy. And that's, of course, based on high-resolution endoscopy with both white light and filters. And I'm going to talk about that in a second. And also with standard chroma endoscopy. First, the first step is, as I've already shown you, to assess the lesions using the Paris classification to make sure that we are dealing with flat lesions, which are our main indications, especially for squamous cell cancer. Just to remember, protruding or excavated lesions are more frequently associated with submucosal infiltration and therefore rarely good candidates for endoscopic resection. Chroma endoscopy is really important, especially when it comes to squamous cell cancer. We use a Lugol's solution, and it's not only important to detect the lesion with Lugol's, but also to assess the lateral margins. It's extremely difficult, in my mind, to really find lateral margins of squamous cell cancers in flat lesions with white light or even with filter technology, and Lugol with its unstained areas is a great help. I'm also a great fan of acetic acid. It's a very handy method not to find Barrett's esophagus, but to assess the surface pattern of the lesion and to find and to detect the dysplasia and the neoplasia, the early cancers. And therefore we should use them in all cases where we plan to do ESD. So what does Lugol's do? Lugol's highlights glycogen-rich squamous cell epithelium. So normal squamous cell epithelium, you get this brownish color, and in neoplasia and dysplasia, we find areas with depleted glycogen storages, and those are the areas which remain unstained. The sensitivity has been proven to be very high. It's somewhere between 90 and 100%. It's not always specific. Also, esophagitis can cause a loss of glycogen, and therefore you have to combine the white light picture with the Lugol stainings just to make sure you don't misinterpret the endoscopic picture. Here you can see a case of squamous cell cancer in the picture on the right-hand side. You clearly see the unstained areas between 1 o'clock and 5 o'clock. And this is the area where we find the cancer. As you can also see, it's a completely flat lesion, so it's really hard to detect with white light only, and of course almost impossible to find the lateral margins. Another case, just to show you the difference, that's the same patient. On the left-hand side, you have a high-resolution white light picture, and if you have a really good screen and a well-trained eye, you might see that there is a slightly more reddish pinkish area between the 11 o'clock and 5 o'clock position with white light, but the image becomes much clearer once you apply Lugol's, usually with a spray catheter, where you can clearly see the early flat cancer. It's a 2B lesion, and of course that's how we identified it and made sure that's a patient eligible for ESD and then performed the ESD. As far as acetic acid, it's very cheap, so usually I use even vinegar if there's no acetic acid available from the pharmacy. It has been shown to increase the diagnostic yield for Barrett's esophagus, but it's also very useful in finding cancer. Again, you see a case of Barrett's cancer in the photo here in the 4 o'clock position, and cancer assumes a pinkish or reddish color. If you use a 6% acetic acid, it usually starts even to bleed, so then it's even easier to find than with the more commonly used 3% solution. Image-enhanced endoscopy, all our scopes now have some form of light filters, and we know that this is most helpful in the esophagus. It's less, I think that's the main indication actually for those filter technologies, be it iScan OE, BLI or MBI, is actually the esophagus. So how does it work? You all know that we're restricting the spectrum of visible light to specific wavelengths that absorb hemoglobin. So we have an increased contrast regarding the vascular structure and as well the surface structure. And this is data from a Japanese study. In this case, they used MBI for the detection of early squamous cell cancer, and not surprisingly, they were much more successful with NBI than with white light endoscopy. And those results can be pretty much copied over to other imaging technologies like iScan OE and BLI, because the principle behind those is very similar to MBI. This is just an example. This is a still from a video I did during one or before one of our ESDs in squamous cell cancer. I didn't find the actual photo, so this is just a shot from the video. Sorry for the bad quality. We're using a magnification endoscopy and iScan OE, and as you can see, because of the filter technology, we can assess the surface, the vascular structure of a lesion. And here we have an intrapapillary capillary loop type 4 V3, and that's an invasive cancer. So based on the image, on the endoscopic image, we decided not to perform ESD and sent the patient to surgery, where our initial diagnosis was confirmed. Another case of a zoom endoscopy with assessment of the surface, the vascular pattern is in a very rare disease, actually. It's Barrett's polypoid dysplasia. So here we're not dealing with flat lesions or mostly flat, but it's really like there was a patient with an esophagus full of polypoid lesions. And she had repeatedly high-grade dysplasia. She had a twin sister which already underwent esophagectomy because of adenocarcinoma, so this is clearly something genetic. And again, you can clearly see the IPCL using zoom endoscopy, using the Pentax zoom gastroscope. And in this case, we were using the digital iScan in order to enhance the vascular structure. Role of endoscopic ultrasound. We all know that for TNM staging or TN staging, EOS is the gold standard, but we not routinely use it in the esophagus before ESD because mostly of the fear of overstaging. In Japan, as you all know, the endoscopists prefer to have a careful look at the morphology of a lesion instead of using EUS. And many centers in the West use the same approach to the patients. This is a Dutch study, 130 patients from a well-known center in Amsterdam. As you can see, predicting the outcome of the patient, EOS wasn't really useful. There was mostly overstaging. There was suggested submucosal infiltration in 20%, which couldn't be confirmed by the histopathology. So we don't routinely use it before ESD. Of course, if the patient is eligible for surgery, then that's part of our diagnostic workup before sending the patient to surgery. As far as complications is concerned, there's good news. Unlike in the stomach and in the colorectum, bleeding is less of a concern in the esophagus. Severe bleeding occurs in less than 1% of cases, be it either acute or delayed bleeding. Of course, we experience bleeding. So in case of mild bleeding, we use the tip of the ESD knife with coagulation. My approach is using not forced or spray coagulation, but mostly soft coagulation or spray coagulation to achieve hemostasis. The advantage of using the tip of the knife, if it's not a non-insulated knife, that I don't have to swap it for another instrument, so I've saved time and money. Of course, we have to be careful not to apply pressure to the wall and to apply the heat only briefly in order to avoid perforation. For larger vessels, we also like to perform hemostasis before it even starts to bleed, or in case of more severe bleeding, we use hemostatic forceps, like the hemostat white cup. First step, of course, is cleaning the area and then to find the bleeding vessel. Then we grab the vessel and apply coagulation current. Again, it's soft coagulation. And depending on whether you're using a bipolar forceps like the hemostat, you use only a minor effect and minor electrical energy, 15 to 20 watts. And you can also push against the wall because the electrical current is only flowing between the two branches of the forceps. If you're using the coag grasper, which is a monopolar device, you have to be a little bit more careful. First, you have to use higher energy levels in order to achieve hemostasis. You need also more effect. And you always have to pull the forceps away from the wall in order to avoid thermal damage to deeper layers. With hemostat, pulling is not needed, and you can use low output energy as you won't need that much to achieve successful hemostasis. Perforation, of course, is the most feared complication of ESD, but it's more frightening than it actually does harm to the patients, and we can also reduce the risk of perforation. First, we do most of our procedures in intubation, although for example, in Austria, we're allowed to do doctors allowed to do propofol sedation. So for ESD in the esophagus, usually I have my patients intubated, which has some advantages. It minimizes respiratory variations and minimizes the risk of aspiration, of course. And also it increases mediastinal pressure, which makes ESD more safe because we have less of a risk of air dissection through the esophageal wall. And of course, it's mandatory for all kinds of ESD procedures, wherever you want to do it, to use carbon dioxide in order to reduce emphysema, be it mediastinal or subcutaneous during ESD. When we have perforations, they are usually very small. And what we usually try to do is to continue our dissection, unless it's a very large perforation. By continuing, we usually can finish our procedure, and then once we resected the lesion completely, we close the lesion with endoclips. And usually those standard endoclips, hemostasis clips, are sufficient in order to close a defect. Again, this is an Asian study, 300 patients with esophageal ESD, perforation, rare complication, 2.2%, but of course these are extremely well-trained doctors. Just read the names of the authors of the publications. They had three perforations during the actual ESD and an additional 3 perforations during balloon dilation for stricture prevention. So that's something I don't do usually, immediately dilate, and we just have to deal with the perforation during ESD. All cases could be managed without the help of surgery. Of course, it includes close clinical and laboratory monitoring, nil per mouth, and intravenous antibiotics. In this study, only 1 patient had to be closed with clips. All the other defects closed spontaneously, confirming that those are mostly small perforations. Of course, we'll find emphysema. And here we have to remember the good old book House of God, that the cardiac arrest, the first thing is you take your own pulse, so keep calm and try and monitor the patient clinically, how he's doing. Emphysema doesn't necessarily mean a severe perforation or severe complication. Strictures are actually the most common complications in ESD in the esophagus. It can be found in 10 to 20% of patients undergoing ESD. It's mostly the circumferential extent of a resection that determines the development of a stricture. So if we resect more than 75% of the circumference, or we have defects longer than 3 centimeters, or infiltration beyond M2, we have to expect a higher risk for developing a stricture. In case of circumferential ESD, and that's nothing new, we knew that from the EMR studies already, we have to we can be sure that the patient will develop a stricture. As far as dealing with those complications is concerned, there are several approaches. I already mentioned preemptive dilation. Metal stents are rarely used. Steroids are the most commonly used, and biologic agents might be an option in the future. The most commonly used method is local injection of steroids, triamcinolone. There is I picked this Japanese study where they did a single injection with steroids and had significantly lower rate of stricture formation. And new methods include tissue shielding methods. You've probably read about those. Cell sheets, which can be either cultured or synthetically grown and then transplanted endoscopically. But those are still a little bit away from daily routine. My personal approach in case of strictures is to, in case a stricture develops, to do a dilation, usually with bougies, and then put the patient on oral steroids. Usually I start with 50 milligrams methylprednisolone once daily per mouth, and then taper every week. And this gives quite good results when it comes to the treatment of strictures and avoiding repeated dilations. This is just such a case. This was a large, more than 5 centimeter, 3/4 of the circumferential resection of a squamous cell cancer. You can see the stricture, which developed roughly 2 months after the resection, and then you can see the image immediately after dilation with bougies. This was a patient we put on oral steroids, and he did well after 2 sessions of dilation. Long-term outcome for ESD, mostly those studies are mostly on squamous cell cancer because all the data is actually from Asia, where squamous cell cancer is the most important indication for esophageal ESD. As you can see, the overall survival rate is excellent, 99%, cause-specific 100% in this Japanese study, and 5-year survival was 100% in M1 or M2 disease, confirming the indications for ESD, and around 90% for patients with M3 or SM1 infiltration. But I think that's still quite good. Those patients with squamous cell cancer in Europe usually have other risk factors like alcoholism or smoking and associated lung diseases. So I think 90% even for an M3 or SM1 situation is a good result. Coming to my conclusions, as far as the esophagus is concerned, endoscopic resection using ESD is the preferred approach for early malignancy. The main indication clearly, be it in the East or the West, is early squamous cell cancer, while patients with Barrett's cancer are best treated with EMR, followed by ablation, be it with heat or cold. ESD for Barrett's esophagus and submucosal tumors should be limited to experienced centers and are applied only for selected patients where either EMR is not a good option or surgery is too invasive in case of submucosal tumors if the patient really wants a resection. The crucial point is to carefully evaluate a lesion, to assess the morphology using the Paris classification, to use image enhancement technologies like iScan OE and chromoendoscopy with Lugol's and acetic acid in order to choose the right lesion and the right patient. If we stick with our criteria, and I've shown you them at the beginning of my lecture, complications are relatively rare and can be managed without referring the patient to surgery in the vast majority of cases. And with that, I'd like to thank you all for joining us in these difficult times and hope to see you soon in person. Thank you.